I'm Shayna Thornton, on air host and executive producer. And I'm so excited to welcome you to yet another edition of Real Talk. It's our video series produced here. And tonight we have a phenomenal guest that's going to inspire, empower, and educate you. And it's the one and only Dr. Lori Johnson. She is board certified OBGYN and a friend of this program. And she's a community educator. And tonight we're going to talk about some important topics. So we're calling all women of all ages to join us for an important conversation about your health. And gentlemen, don't leave us. Please stay with us so you can be educated and informed as well. But tonight we're going to cover three areas briefly. We're going to talk about menopause, which every woman is going to have the opportunity to go through. Is it as bad as it seems? Where Dr. Johnson is going to dive into that, and she's going to bust all of the myths wide open and give us some real facts. We're also going to talk about fibroids. So many women suffer from fibroids. Is there a cure? And will you have to suffer and live with the condition all of your life? Dr. Johnson's going to address that as well. And last but certainly not least, we're going to talk about fertility tonight. And we're going to talk about fertility for the women that happen to be in their 30s and 40s. So what a great conversation. Dr. Johnson, I am so excited to have this chat with you. Welcome to the program.
Thank you, Shayna. It is so great to be here. So good to see you.
Oh, awesome to see you. Now, one of our traditions here on Real Talk, produced by Let's Talk America Radio, is we love to hear from our exclusive guests themselves. Now, I've seen your CV or your resume, and I know you're board certified, you're award winning, you're amazing, all that and more. But in your own words, 2 minutes or less, tell us what got you here. Why did you want to be an educator and work with so many women when it comes to their health? Was that a spark that was in you as a little girl?
I have always wanted to be a doctor from the time I was about 5 years old. And somewhere around high school, I felt that women's health was going to be it. OBGYN, I think the birth process is fascinating. And women are really some amazing creatures. We do amazing things, and our bodies just do what they're supposed to do naturally. So, and most of us don't know what our bodies really do, what we're capable of. Most people have a health class in 7th grade, and that's kind of what it is. And we just figure it out from moms and aunties and grandmoms. So what I try to do is bridge the gap from what we think we know and what we know to what's fact versus what's fiction, and to really relieve some of the fears and concerns that most women have.
Yeah, I love it. I love your passion and your compassion for helping women really stay educated about their health because they have one body. And let's dive right into it. I said we were going to start off with a topic that's trending, menopause, okay, the M word. As you and I both know, women will have to take that journey at some point. Let's start off really basic. I don't want us to overlook the obvious. Tell us what menopause is, and tell us the details of around what age do most women experience it? And I've got to ask this question, is it as bad as many women say it is?
By definition, menopause is the absence of a menstrual cycle for a full 12 months. So when your cycle has been gone for a whole year, you are officially in menopause, right? Average age for that to happen is 51 years old. It can happen as early as the mid or early 40s, or as late as like the mid 50s, 55, 56. However, the part that you hear about is what they call the perimenopause. So that's the time in between everything is normal and everything is stopped. And that's usually the big transitional phase where your hormones are kind of all over the place, and you're having these hot flashes and mood swings and all these other things are going on. And that's the area that women mostly struggle with. And that's the area that a lot of women don't talk about. We don't know. Our mamas just dealt with it. But now we're career women. We're working in our 40s and our 50s and our 60s. And, I have so many clients who come in like, I'm mid-presentation in front of a room full of men, and I have a hot flash, and I'm sweating profusely, and I look crazy. What do I do? So that's why it's becoming such a great topic, because there are so many women who are in certain spaces that have to manage menopause and manage what else they have going on in life.
Wow. And that thing called life never stops. If it's a job or taking care of children or grandkids, it does not stop, or being a caregiver. Now, you said the true definition of menopause is going 12 months without a period. I've got to ask this though. After 12 months, you're saying she's entered menopause, but does
Right.
that mean that next year she could still spot? Is that a possibility?
She should not at
Okay.
all. Once that 12 months have passed, you should not have any bleeding after that. If you do need to see your gynecologist and
See.
find out what's going on.
I see. So there could be some concern there. You're not saying not necessarily, but go see a physician immediately.
Right. It doesn't just
Okay.
come back after X amount of years. And that's unless like now some instances may be women who are going through chemotherapy for like cancer
Okay.
or sometimes the chemotherapy will shut down a lot of the hormones. When the chemo is over, they may see a cycle again or something like that. But if it's just an organic, the cycle's gone for a year and there's nothing else going on, and you should not see bleeding again.
I see. Okay, so that's great information to know. Now, you said that, of course, there's that stage during menopause where women will complain about the hot flashes and even the
Right.
mood swings. Tell us the solution to this. I mean, one, I'm sure as a board certified physician, I'm sure there may be some options out there that are available. And if so, are any of them natural, or do you suggest things that are non-pharmaceutical, such as exercise or meditating? I'm just throwing that out there. I have no idea if that's effective or not.
It really depends on the symptoms and the severity. Every woman is a little bit different. So some
Okay.
of you will have a lot of changes. Some will have very few changes. They'll be like,
Oh,
I
wow.
feel fine, so it just depends on the individual. What I will say is this: most people who seek treatment for menopause from me are married or in relationships, because one of the other things is the mood swings, it's the sweating at night, it's the can't sleep, it's the focus,
I
you're
see.
cloudy, you can't get your thoughts together, forgetfulness, weight gain,
Okay.
different things like that. And people tend to seek treatment when they're with other individuals in close proximity, as opposed to they're single, they come home, there's somebody there but them, and if they're just they're a little crazy, it's okay. But that's that perimenopausal, because what sometimes the cycle can like be gone for 2 or 3 months, then it'll come back. Then it can be gone for 2 or 3 months again,
See.
then it'll come back. It'll be gone for 6 months, then it'll come back
I
in
see.
that transitional phase. And that's where most people struggle the most. And that can last about 2 to 3 years, depending on the individual.
Wow.
Like that back and forth all over the place can last a while. So that's when most people seek treatment. Now, I have clients who come in and they only want to do like herbs and evening primrose oil and
Okay.
ashwagandha and things like that, and that's fine. I have some who are like, I'm gonna be crazy. Please give me some kind of hormones, et cetera, et cetera. So it just depends on the individual. What I tend to do in my practice, though, across the board, is I try to lean toward what they call bioidentical hormones, and these
Okay.
are hormones that are formulated in the way that your body has made them, because your body makes hormones, right? So menopause is basically when your body runs out of hormones and could use a refill.
I
So
see.
I tend to go towards the bioidentical hormones that are the same chemical compound that your body was already making. So that when your body gets them, it knows how to process them and break them down. That's versus the synthetic hormones that are made in labs that are similar to, but not exactly the same thing. And they're the ones that we see issues with, causing, cancers and other things like that, as
Yeah.
opposed to the bioidentical ones.
Okay, and thank you for pointing that out, because I know some years ago, maybe it was over a decade, that hormone replacement therapy had started to really have some naysayers because of some side effects or some other health conditions associated with it. You're saying there are options out there that are certainly much more natural. For those solutions to help women get through that perimenopausal stage where they're having a lot of issues, I would imagine, though, the therapeutic solutions would be temporary, right? Because at some point she's going to come out of it.
As someone, she's going to come out of it, yes.
Okay.
And it just depends on how long it lasts that she has to kind of do treatment. What we do try to do is, if we have someone on treatment, try to wean them down to the point where they're kind of like, okay, we're feeling pretty settled.
That makes sense. You're watching Real Talk, produced by Let's Talk America Radio. I'm Shana Thornton, on-air host and executive producer for the award-winning program. We are talking to the one and only Dr. Lori Johnson. She is board-certified OBGYN. She is based in Atlanta Metropolitan. Her practices in Locust Grove, Georgia, and she is educating us on an important topic, women's health. We are pinpointing menopause, and she's already enlightened us with so much great information. I have to ask this because it is Real Talk for real people, right? As our slogan says. You said that often women can go really up to 2 years of not having a period or a cycle for 2 months, and then it can come back, right? Or it can be 6 months and come back. I have heard stories all of my life, and these aren't urban myths. I've known women who this happened to. They thought they were going through the change, as many individuals in the United States, especially the Southeast, will say, and she thought it was over, and she had an unexpected pregnancy because she was not, and not, using just some words here, she was not menstruating or bleeding for a while, and that was her assumption. Talk to us about that. I'm sure as an OBGYN, you've had a few cases where that woman assumed her fertility was zero. She, her and her partner kind of had the green light to go, and it didn't always end up that way if they were trying to avoid having additional children.
Well, there's a common misconception that after you get to a certain age, it just can't happen. Like all of a sudden you turn 45 and your body's like, no, it's not gonna happen. And I don't know where that comes from, but that's wrong. It's wrong. If you
so say that again, Dr. Johnson, so it's clear on Let's Talk America Radio.
It doesn't just shut off at a certain age where you just can't get pregnant after 40, whatever. You definitely can. And if you're not on any kind of contraception, your tubes are untied, your husband hasn't had a vasectomy, you're just, having sex with your husband. And, if you ovulate once a year, that one time could be the time that boom, and now you have this baby at 40 something and you're like, what happened? So yeah, I tell people all the time, I'm 40 something. I'm like, okay, well, and sometimes what I said was, let's do your blood and see how close to menopause you are. There is a blood test we could do, particularly called a FSH, follicle stimulating hormone. And the higher that number is, the less likely you are to get pregnant. The lower that number is, the more likely you can't, is a possibility still exists. So we'll test them and I'll say, well, hey, you're not there yet. I know it's been a couple months you had a period. You're not there yet. You might want to be careful. I mean, the odds are lower that you can get pregnant. The rates are much lower after 45 or whatever, but it's not impossible. It can still happen.
Yeah, and education is key and awareness of it. You did mention, of course, you said for women, if they are trying to prevent pregnancy, the contraceptive something, and have that conversation with their OBGYN about it. You also said tubalization, tying tubes, which is a very popular practice here in the United States. Once women decide at whatever age that she is done having children, I've got to ask this, how long is the tying of the tubes or tubalization, how long is it effective?
Ideally forever.
Okay.
Once it's done, it's over.
Okay, wow. Okay, so great information. Now I want us to transition into a very popular topic that a lot of women may experience, and even those who are going through menopause. And there are a lot of myths connected to this topic. And I'm talking about fibroids. As you know, of course, benign tumors that thousands, if not millions, of women have here in the United States and certainly around the world. Tell us exactly what a fibroid is. Is there ever a need for a concern? And what symptoms, or in particular bothersome symptoms, can it cause? Because as you know, there are so many women that do request myomectomies, hysterectomies, and of course embolization procedures to shrink them or get rid of them. Help us out.
So fibroids, as you said, are benign tumors that grow within and around the uterus, right? So the uterus is a muscle, smooth muscle, right? And it looks kind of like smooth muscle. So they can grow within the muscle wall, they can grow kind of on the top or within the actual cavity, the lining of the uterus. And they can get very large. They can be as tiny as a pea, they can be as large as a cantaloupe, they can be every size in between. And you can have one or two, you can have 20. It just
Oh,
depends
wow.
on the individual. So we don't know exactly what they're caused from. We do
Okay.
think now that diet has a lot to do with it. They thrive off of estrogens, which is the female hormone, but it's also in a lot of our foods. It's in a lot of our it's in our dairy, it's in our chicken, it's in our beef. So that feeds it. They do tend to run in families, but then I have several clients who
I
have
see.
no family history at all of fibroids, and they have some very large ones. Um, Fibroids they can do a couple things. They can cause, the main thing they can cause is very heavy bleeding, very heavy periods. And when I say heavy, like, you're putting on like the overnight pads in the daytime and you're changing them several times a day. I've had clients come and tell me they wear Depends when they have their cycle because that's how much they're losing blood, or they're having accidents and having to soiling their clothes and can't wear light colors, only can wear black during that time of the month because they routinely bleed, quite a bit and bleed through.
I
That's
see.
one. Also painful periods, just cramping, etc. Heavy cramps that kind of they started as they got a little bit older, started having heavy cramps they didn't have when they were younger. Fibroids can cause that. And then lastly, they're solid and they're large, so they can be like, you can look puffy, like you have a big tummy, like if you look like you're pregnant. That you can have constipation issues because they can press into your intestines and block those. You can have frequent urination because they're pressing upon your bladder. So they become like bulky, it's just like you always feel bloated, always feel like you're full, you can't eat properly because you have these fibroids that are taking up a lot of space. So those are the main symptoms that we got to look out for. And I'm going to say this to any women, especially women of color who are watching, don't just ignore it. When you're bleeding so much, when you get to when you have to wear Depends on your period, you need to see your gynecologist. It's too much.
Yeah.
It's just too much. And people kind of just get accustomed to it, and they get used to it, and they become very anemic and they need blood transfusions, et cetera, et cetera. But yeah, those are the main things that fibroids cause.
Yeah. And thank you for educating us. We are talking to the one and only board certified OBGYN, Dr. Lori Johnson, and she now is covering fibroids, something very common in many women, in particular women of color. I know you mentioned sometimes they can run in families. We talked about that before. How much of a family link is it? I mean, if moms have it, is it often that all of her daughters may have it, or there's a very high chance?
And about 50-50. It's not
Okay.
necessarily that direct. It's about 50-50 chance. I believe a lot of it is dietary, though. A lot of it is how we're eating. I see younger patients now with fibroids than I used to. And I heard a study kind of in passing that they were linking some of those problems to ramen noodles, the packages of noodles, because
Wow.
they're very high sodium, and whatever they make the noodles out of is a lot of chemicals. And I've heard that they've linking those issues to high consumption of those foods, and we know they've become almost a staple in many households.
Yes.
People eat noodles every day, so
Yeah.
because they're filling and they're cheap. So
Yeah, especially college students.
especially college students. Yes, exactly.
So I've got to ask this question. So with fibroids, obviously, and am I correct to say they are fed by estrogen? Is that
Yes.
accurate? So my thinking, and you tell me, you're a physician, I'm not, but as a woman gets older, we are told her estrogen level drops, right?
Yes.
So that's why a lot of times she can have high HDL when she's 28 years old. By the time she's 48, it plummets. So does that mean that the fibroid can very well possibly stop growing while that woman's going through menopause or after she's completed menopause?
Yes. So after menopause, yes, they will shrink some, not go away, but they'll shrink some and they'll become what they call calcified. So the texture of a fibroid is kind of like that of a raw potato. It's a little bit firm, a little bit spongy. After menopause, when the blood flow and estradiol goes down, they become harder, almost like remember them jawbreaker candies back in the day, like kind of hard like that. They don't go away completely. So I have some menopausal clients who still have bulky uteruses
Oh,
because they
okay.
still have fibroids, but they don't believe there's no issues or anything like that.
I see.
The problem is in that perimenopausal period I told you about, because
Yes.
before menopause, the levels are kind of like nice smooth curves. During
Okay.
perimenopause, they're kind of more jagged. So when those hormones really get to shifting, some fibroid patients can really have issues with bleeding that doesn't know how to cut off. Like they'll get a period and they're bleeding for 2 or 3 weeks, and it's really, really heavy. So that's the problem with fibroids as it relates to that menopausal transition. Once they're all the way finished, they're not going to have too many issues except for the
I
bulkiness.
see.
But in that meantime, they're going to have a lot of problems.
Let's talk about the solutions to it, because I know many years ago, about 30 years ago, I think many of the women, my mother's age and aunts, they would say it was kind of a hysterectomy. And now, and I'm sure my myomectomies could have been around then, but I think as OBGYN, I would imagine it's probably a little more done today than it was 30, 40 years ago, if
Right.
that's true.
Right.
And sort of tell the women what their options are. Not saying hysterectomy may not be an option for a woman watching us tonight, but let her know there are other options as well, because better than I do, because you're an OBGYN, that with the hysterectomy, of course, you are removing a part of the uterus, if not all. Or help us out, tell us about what the hysterectomy is and the options to treating fibroids.
Sure. Well, again, about 30 years ago, it was OBGYN was a male dominated field, right? And so it was men, and their concept and the mindset was, well, if you're done having kids,
Okay.
just take it out. You don't need it. Get rid of it. Little historical fun fact is the whole word hysterectomy came from the word hysteria. You may know that. And they used to say years and years ago that when women were crazy, if they removed the uterus, they were hysterical. The hysterectomy, that's the root of the word hysterectomy, they would cure them of their hysteria by getting rid of the offensive uterus. So that that concept of you don't need it anyway, get rid of it. So a lot of times hysterectomy was just first line. You go there, I'll say, we'll just take it out and you'll be done. But if you may not want to have your body parts removed, or you may
Yes.
not be done having children. You may have
Correct.
had no children at all. So now that's called a myomectomy, where you take the uterus and shell out the fibroids, remove them individually. Fibroids can shell out kind of like old school peas in the shell. They kind of
Okay.
shell out that way when you're doing a surgery. And so you can remove 1, 10, 15, as many as you like for that patient. And then in recent years, maybe 10, 15 years ago, they have the UAE, which is the uterine artery embolization, where the radiologist goes in and he plugs off the arteries that feed the uterus, thereby decreasing the blood supply to the fibroids and causing them to shrink. They kind of like emulsify and get smaller. Now they don't go away, like they don't just disappear. They're still there. They're just they're no longer active, and they're not bothering you at
I
that.
see. I see. Wow. So there certainly are solutions out there. I do want to ask this when it comes to the myomectomy or the artery embolization. I guess there's always a chance they can grow back, or new ones can grow. Is that correct, doctor?
That is correct. Sometimes when you're doing like a myomectomy, for instance, depending on like if they're really, really tiny, you don't want to have to dig to get it out.
Yeah.
You might leave it. That has potential to grow again. It doesn't happen classically, but it can happen.
I see, and certainly can. I want to talk about, and thank you for pointing out that women do have options. You're saying that it may not be, she may be done with kids, but that doesn't mean she wanted her body part removed. As far as the uterus is concerned, and this is me, no physician, don't play one on TV, but I do have the honor of interviewing Dr. Lori Johnson tonight on Let's Talk America Radio edition of Real Talk. But if you remove the uterus, are there any studies that suggest there could be other issues? When I'm talking about the hysterectomy, could there be hip issues or leg issues? And I'm just sort of throwing this out here, if that uterus is removed.
If the uterus is removed, not classically. There are you can have some damage to the ovaries, which are kind of hanging on the side, and you can have some menopausal symptoms as a result, but not you can have issues with sexual functioning as well. Some women feel like sex isn't the same when they have their uterus removed. Some say it's okay, some say it's not. It just depends kind of on the individual.
Okay.
But nothing that's like particularly those kind of issues, hip issues and back pain.
Now, talk to us about the different types of hysterectomies, because I know there are complete ones someone can get, and then there's a partial. What's left behind if there's a partial?
Well, a partial hysterectomy would take the uterus itself out. So the part that bleeds, the part that has babies goes out, and they would typically leave the ovaries behind. The ovaries are kind of what governs the whole menopause and the
I
hormone
see.
production. So they'll leave them in. So woman could have a hysterectomy, no longer have a period, but not be in menopause when she wakes up. If you take the ovaries out of a woman, then when she wakes up from that OR table, she's gonna start menopause like the next day because the
Immediately.
was out. Mm-hmm.
I see. Wow. Interesting information. Being educated here on women's health with Dr. Lori Johnson. She's a board certified OBGYN out of Atlanta Metropolitan, Locust Grove, Georgia. And oh, what a conversation, one that's shattering some myths from us. And we certainly thank you. As we move to the next topic, I have to ask this though, because when we're talking to a physician of the caliber that you have and possess, I've got to talk about screening. And when we talked about removing the uterus for a partial or full hysterectomy, I would imagine, and not that this would ever for every woman be a reason to advocate a hysterectomy if she has fibroids or some other conditions, but if she doesn't have a uterus, I would imagine that would remove her risk of uterine cancer. Am I right?
Yes, that would.
I see. Okay. I see. And I want to talk about screening right now briefly before we move to our last topic tonight of fertility. But we hear so much right now about some celebrities in high profile roles. Angelina Jolie was one of them. And she's been very candid and transparent about the female cancers that have been in her family, from her grandmother, from my understanding, aunt, and her own mother. And she voluntarily opted, and help me out, doctor, if I'm right or wrong here, to remove ovaries and her uterus, if I'm correct. And that was optional that she did because she did some testing that did suggest that she was at high risk. And I would imagine, this is me saying this, even without the testing, you look at your mother, your grandmother, your aunts, I guess some of that, and you would say that too, with some just basic screening that would put that person at a higher risk. Talk to us about screening, and even when it comes to the PAP, right? Even when it comes to that and screening and how critical that is, and touch a little bit on what Angelina Jolie did, because I think more and more women are seeing that as a viable option. And give us your professional take.
Sure. So, unfortunately, all the parts can get cancer. So the cervix, which is the very bottom of the uterus itself can have endometrial cancer, and then the ovaries can have ovarian cancer. So 3 kind of different types, and they can all cause problems depending on what you're doing. So the PAP, which we were recommending between every 1 and 3 years, the PAP smear is when you come into the office to put the speculum in, take a sampling of the cells on the actual cervix, and that's the outer part of the uterus. That's when the part that when you're in labor and they say you're dilating, that's what's dilating is your cervix. That's the very bottom part. That should be done on a regular basis. And that's the easiest screening to do, because you just kind of come in, we do it real quick, and you go on your way. The uterus, etc., is a little bit more involved because that's kind of hidden and tucked away. It's also, the uterine cancer is also the rarest, but the most survivable cancer of them all. It's called endometrial cancer. And you see that typically in women who are either very obese, or like just older women. That's when that postmenopausal bleeding, that could be maybe endometrial. Ovarian cancer is what Angelina Jolie has, or had. It's in her family rather. And that is probably the worst of the 3, with it being the most, it sneaks up on you. Unfortunately, there's not a lot of fantastic screenings for it. It kind of comes on quick and it comes on hard. And it's the worst of the GYN cancers to actually have to deal with. However, now we have tests. We have not just BRCA, which is the breast cancer, ovarian cancer screening, but a full gamut of tests. And if you have a mother, a sister, a aunt, a grandmother who has had ovarian cancer, who has had breast cancer,
Okay.
you can get testing. And most of the time it's at nominal cost, if not free. So if
Okay.
you ask your gynecologist, if your mama had ovarian cancer or something, you can get that tested for free. And that will tell you your risk assessment. Do you have that gene
I
that
see.
will cause ovarian cancer? That's what Angelina Jolie has. And so she opted to remove the ovaries to prevent getting that cancer.
I see. Wow. And such a bold move. And I think one that is brave as well. I have to ask you this. You're in practice. Obviously, you see hundreds of patients. Is that something that is catching on with the everyday mundane woman? And I want to be upfront with you because it's real talk for real people. And I think there's always the challenge of, do people want to know, right? That's just a human component, Dr. Johnson. We've got to be real, right? If we're going to break barriers for everybody to confront real health challenges, do people want to know? Does that put a cloud over things? Will it kind of stop you living your life, or do you make the decision to take it out? I mean, obviously, you're a physician, which means you do have to be a psychologist and many other things to people. But what would be your professional take on people if that risk is there?
Well, you're right. Some people don't want to know. They'd rather not find out. They're like, and we offer it. If I'm reading their history, they have, these different things. Some go, no, I don't want to know. I'll just figure it out along the way. Okay, because again, once that happens, you have to say, well, now do you want to have surgery? Do you want to have your ovaries removed? And what does that look like? And all those types of things. So some do. I actually have a client now who got tested and had a high risk chance,
Okay.
and has unfortunately developed ovarian cancer. She had seen a different doctor before me, and she thought her ovaries had been removed, but they weren't.
Oh
And
no.
so she thought that doctor took them out, but they hadn't taken them out. And so then she went ahead and developed ovarian cancer as just a few months ago. She's doing well though.
Good, good. And I know you would say screening and is important and critical, and early detection. I hear that so many times when we talk about breast cancer, when we talk about colon cancer. But how key is that for all of the cancers that can affect the female body parts?
It's key. You can't beat it, because early detection, even if I'm doing a surgery if it requires a surgery, the type of surgery we have to do can be a much less invasive surgery versus a huge surgery. If we can catch something early and follow up. For cervical cancer, for instance, one of the main risk factors is long interval between
Visits. Okay.
I have had a young African American woman present to me. I think it was late last year, and while we're talking, I'm just going to divert a little teeny bit. So, cervical cancer, one of the signs is bleeding after intercourse, bleeding after sex. When you hadn't had that issue before, you have sex and you start having some bleeding, even if it's a day or so. And she had been bleeding after sex for over a year. Oh, wow. And hadn't come to see me or see any gynecologist. And she had a large cervical tumor on her cervix. But just that, that's not normal. If you never bled after sex and you start, that's not normal. You can't just pretend it's not gonna.
Yeah.
So if you see it, had she come in the first time it happened, she would have been a stage 1 or instead of a stage 3 by the time she got to see me.
And obviously stage 1 is lower, stage is less aggressive. And the higher it gets for any cancer, it's more of an aggressive form of cancer, right?
Or it's more spread. The cancer is measured based on how involved it is with the tissue itself, how large it has spread to other organs. Is it in the lymph nodes? Is it in other places? So the smaller the tumor and the less it's involved with irregular tissue, is the lower the stage.
Yeah. I recently read when it comes to ovarian cancer, that, like you said, it was hard to detect with it. And I know when women go to see their annual women's exam, or they're going one to every 3 years, obviously there's a PAP. Obviously there is a uterine check that I think most OBGYNs would do. Obviously, so it's checking any abnormal growth in the uterus. But when it comes to the ovaries, I'm assuming there's not a physical exam you could do to see if there's any abnormal growth?
No, when we're in there checking and feeling around, we're feeling for the ovaries too. And
Okay.
so if an ovary is enlarged, you can feel the size difference. You can feel if it's harder, if it's firmer, if it's softer, you can feel different things.
And I just wanted to bring that up because once again, it's showing how critical it is to get in front of your provider, your OBGYN, so she can do those physical exams to try as much as possible to catch abnormal growths that are going on in the body.
Right.
Yeah, because those are things the woman may not notice herself, right? Obviously, because she doesn't know how, she's not a board certified OBGYN giving herself exams. I do want to touch on this before we go to fertility, but when it comes to self exams, I know so many OBGYNs like yourself really emphasize self exams when it comes to the breast. How critical is that? I've seen some things where people were saying it's not as important. What's your professional take on it for women to be doing that monthly, or how often should a woman do it?
They should do it monthly. And I think that what I know is that what I try to encourage with breast exams is you have to know how your breasts feel normally so that when something changes, you can recognize the difference. And that's the main thing. It may be a little lumpy or whatever, but you have to know this is normal for me. And then this is not, you have to know the difference.
And I think that's so key, because I think you're absolutely right. If you're doing a breast exam once every 6 months, you don't know what is normal. But like, to your point, if you're doing it often, you know what it feels like before your period comes on, while your period's on, and afterwards, right? So that's key. I did want to touch on one last thing, because we have an in-house expert. We've got to ask these questions. You said some women breasts can be lumpy. You need to know if that's normal or not. I have heard that there are many millions of women who do have dense breasts. Really quickly, can you describe what that may feel like and how normal is it? And it may be, I guess, an abnormal normal for many women.
Right. So the just a quick history of mammograms. So mammograms are designed to see through fat, right? And so when we put your breast in this machine, they smash it. They hoping to see more fat than thickness, like fibers and stuff. So the density is just that your breasts are more fibrous. They're actually a little healthier. They sit up a little higher, a little perkier. And so they're harder to see through. Not a bad thing, but sometimes requires a second look so they can kind of sift through and see all the things they need to see through them. Even with that, you can still feel your breasts. You can still know, again, which parts feel fuller, which parts feel fatter. So you still can know what the difference is.
Okay, good. Thank you so much. So it's important to get that annual mammogram every year.
Absolutely. Absolutely.
Awesome. I want to transition to our third and final topic, which is fertility. Take it away for us.
So, fertility, is a big thing we have to deal with all the time. Our women want to get married, or they're with a partner and they want to have a baby. I want to start this by saying this little known fact right here, and that is absolutely that 4 out of 10 couples have male factor infertility. And what that means is that 4 out of 10 couples, it's his problem. The assumption is classically that the woman has the problem based on her irregular cycles or something else she has going on. But 4 out of 10 times, it's the guy. He may have an issue with his sperm count, or his sperm don't swim properly, or his sperm are abnormally shaped. And so it behooves any couple that before you dive deep into the infertility treatment cycle, that one of the first things they're going to tell you to do is bring your partner in and let's get what they call a CSA, or a comprehensive semen analysis, to see what he has going on. So I'm just going to put that up front, right? Now, with other infertility, things like fibroids, endometriosis can limit your fertility. They can limit like where if there's scar tissue from endometriosis or adhesions that have the tubes blocked, that can be an issue. Sometimes with the fibroids, if they're inside the cavity, it can present a problem with the fetus implanting on the inside wall of the uterus. So there's different things that we have to look at and evaluate. The main thing is you got to have a period every month. You got to have a period every month. That's what you got to do to get pregnant. That's one. And then two, there's only about a 6-day window every month that you can conceive. And that's around ovulation time. So you typically ovulate about 2 weeks after the first day of your period. So if your period starts on the 1st, you're going to ovulate somewhere around the 15th. And there's about a 3-day window on each side of the 15th that you can most likely get pregnant. Other days, it's not much going to happen. You're just going to have sex for fun, you know? So, so, you know, you have to remember that kind of the only time you have. And sometimes it's scheduling. Sometimes it's, you know, if he's gone every other weekend or he drives trucks and he's out every other weekend, you're probably missing the window pretty faithfully because he's gone, you know? So things like that also come into play. But if you're having an issue and it's been a year and you've been like making sure you're checking your ovulation, you have your apps and stuff, and nothing's so happening, then go see your doctor and get blood work done and make sure that we're ovulating properly. Now, if you're older, say if you're 40 or late 30s and you're in that space, I wouldn't wait a year. I would say give it 4 to 6 months max and then go see. Because once you get in the 40, you don't have several years left. You got a couple good years to really make something happen.
You know, it's Real Talk for Real People. We are talking to the one and only board certified OBGYN, Dr. Lori Johnson. You did say a woman in her late 30s and 40s. Obviously, she doesn't have the time necessarily to wait when it comes to fertility. Obviously, you and I both know women have different journeys, right? Some go to college to be physicians. Some go to colleges to be publicists, whatever they do. But obviously, sometimes they are family planning along the way or know they want children later once they have established things. But I think I want to talk about a myth that is out there when they say it's easier for younger women to become pregnant than women that are over the age of 35. Is that a myth or is that true?
That's true.
Okay.
It is definitely true. And maybe not even 35. I will say like 35 is where they kind of cut you off at, but I'll say like 38, 39 is when it really starts to get tight. 35, 36, most people can still get pregnant pretty easily.
Okay.
But 38, 39, heading into 41, it may not work.
I see. Obviously, when we go back to the 7th grade health class that you mentioned, I was paying attention. Obviously, women are born, you and I were born with our eggs at birth. But I have to ask this, are there deficiencies that some baby girls may have that they may not be born with the thousands of eggs that you and I were born with? Is that possible?
Yes, it is. There's certain developmental things, certain genetic things that a girl child may not have all the eggs that she's supposed to have. And so, you know, every month as you pop in a few off, you have a lower population to start with.
I see. So that's key to remember. I want to say this, let's talk about the options to fertility. What options are out there?
Well, of course, start with the workup and see what you're going to do. So classically, if you're coming in, we'll talk about, and you've been trying, we'll go to oral medications first. So those are things like Clomid, like Letrozole. Those are ovulation induction agents. So they're going to, if a woman doesn't have particularly regular cycles, we can get her on a cycle, but she's having a period and she's ovulating when she's supposed to ovulate every single month. That's kind of like first line therapy. Then you go a little bit deeper. You can do injectables, and if her husband or partner is good, you can do what they call an IUI, or intrauterine insemination, where I just take his sperm and, for lack of a better word, turkey baster it, and you kind of inject it into the uterus at a
Okay.
specific time so that it has a better chance of getting to where it's supposed to go. And then, the higher level is like, IVF, or in vitro fertilization. And that's kind of like MASO, where you have injectable medications, and that's more of a process where they're, they're growing, developing several eggs, pulling the eggs out, taking the man's sperm, spinning it down, cleaning it up, getting all the good sperm out, sucking them all out, and putting them in a little dish with the eggs, and see what fertilizes rather. And then you're going to put them back in the woman and see what takes. And that's kind of like Max. I mean, now they have it so you can pick the gender. You want a girl.
I know.
Boy, you pick that X.
And if I'm correct, Dr. Eye Color has gotten that advanced.
Yeah, it's the human genome mapping is so intense. You can, want this,
Wow.
and the blind head one, and so it's very, very intense. If you want to go to that space and go to that level.
Yeah, I have to ask this though, real talk for real people, and we want to be fair and balanced on this show always. And such great information being provided by Dr. Johnson. Remember, this is for educational purposes only. For your own specific health questions and concerns, you're always highly advised to visit your own personalized medical provider for those answers. But when we talk about in vitro, and you said genome mapping, and I've seen stories on where you can pick eye color and hair texture, and it's gotten that advanced. I think I already know the answer to this, but I'm going to ask you as an expert, as an OBGYN, a women's health expert. Do we have long-term studies on any of this in terms of the genome mapping in children and the health? I mean, do we?
We don't. One of the things that health, one of the things that they're picking out, like some of the bad genes. Like, so if there's a gene that has like, muscular dystrophy, let's just say, which affects boys, they can pluck that one out and still get you a kid with no muscular dystrophy, because that's what they call an X-linked disease. So it is being used for good in those cases, to kind of pull out some of the highly transmissible genetic problems, and making sure that those offspring don't have some of them. What it's going to be in the long term, we don't know, because we've been doing it to that level for that long, to kind of know what the long-term outcome will be.
I see. That's interesting. So in a lot of ways, science has sort of changed nature. What would have happened naturally with happenings in children, that it's changed the scope of it. For those people that opt to do it, I also want to be fair and just ask a question that I think I know the answer to, but those approaches can become very expensive, correct?
Very much so. Very much so. IVF, I think, is between $10,000 and $20,000 per cycle.
Wow.
A cycle. So typically they say like 3 to 4 cycles have to be done. So that's the medications and the extractions and all that stuff. So it's the $1 million baby for real.
Literally. And I'm going to ask you this because you're a physician. Does insurance tend to cover that or no?
The best insurances may cover a portion of that.
I see.
I don't know if any covers all, especially here in Georgia. Now, some other states, they may cover insurance, varies from state to state. Some states may, but here in Georgia, I think they only cover some of the meds, and it depends on who it is.
Yeah. What an amazing conversation about so many topics, from menopause. We talked about fibroids. We talked about screening for cancers that do affect women's body parts. And last, we talked about fertility. I cannot have a doctor that is board certified in OBGYN on this program without talking about something that's very relevant and very timely, that has been in the news for the last 2 years. And that is the increase of STDs in the United States, emerging out of COVID. Not sure why that is the case, but as someone who sees hundreds of women a year, talk to us about the importance of STD prevention, protection and also screening, because you as much as you deliver the beautiful bundles of joy and babies and consult with women about their different fertility options, I'm sure they're also unfortunate and tough conversations to have about STIs and STDs that have come across as well.
Yes. Yeah, for sure. Yeah, they're on the rise. I mean, we see, gonorrhea, syphilis, chlamydia, herpes, several of these all the time. And it's just unsafe sex practices. You have to just, as a woman, as a younger woman, as an older woman, you have to protect yourself. You have to, if you're having intercourse, wear a condom. If you meet someone and you're thinking about having intercourse with them, show me your papers or let's go get tested together. Something that, and those are uncomfortable conversations for people to have. So I understand why they don't necessarily want to have them, but you kind of have to have them because you're getting that you can't ever get rid of. With chlamydia and gonorrhea, they can turn into PID or pelvic inflammatory disease, and they can cause infertility. They can cause issues. So you have to just be careful, and they're just on the rise. We're just not being careful. HIV is on the rise. Numbers are still high, going up high every day. I think we're desensitized a lot to it, the younger people especially, and so they're like, "Oh, okay." I have to say this, and I'm not trying to bash the fellas, but men, you can't be cheating. You can't put it. You got to be careful if you're going to be out there trying to step out on your wife. Don't, but if you must, please put a condom on and don't bring it back. And I have to call your wife and tell her that she got an STD, and then she want to fight me because I'm just a gynecologist. I'm just telling her the facts. I'm not trying to, I got to tell her she mad at me, she mad at my staff, and you did it. So.
Yeah. Don't be mad at Dr. Johnson. She's one of the best out there trying to educate and empower women of so many different backgrounds on so many important topics. Dr. Johnson, what a pleasure to have you on Let's Talk America Radio. What an important and timely conversation, a tough conversation with some topics many people may not be comfortable with, but I happen to believe here on the program that education is key, and it allows us to make better decisions. And so we can have the great life that we are intended to have, as long as we're empowered with the right education and not the myths that are out there. We covered so much tonight. Tell our national and international listeners and viewers where they can find you and more about you and all of the education that you provided us tonight.
Thank you so much. Well, as she said, I'm Dr. Lori Johnson. I own and operate Just For You Women's Healthcare in Locust Grove, Georgia. You can find us on the internet at Just For You OBGYN. You can find me on Instagram, and I'm trying to be a TikToker at Dr. Lori J. That's Lori, LORIEJ. You can find us on Facebook at Just For You OBGYN. You can follow, I put videos, and there's some educational things on there. So by all means, come check us out.
I love it. I love that you're on TikTok.
Yeah. Yeah.
Staying relevant.
I'm trying. It's a lot. It's a lot.
Well, you're doing a great job, and all the education that you're providing makes all the difference in allowing people to make the right decisions. Oh, what a pleasure, everyone. Please be sure to tag someone you love, male or female, because education is power, because she talked about a lot of topics that does affect the males. If you're a father, if you're a partner, if you're a brother, please make sure you watch this episode. And of course, we want all the women of all ages to watch this episode as well, because it is education. It's for entire family. Every family member can gain from this important episode of Real Talk, produced by Let's Talk America Radio. I am Shayna. We have with us the one and only Dr. Lori Johnson on this important conversation, where the three big ones that we covered was menopause, of course, fibroids, and fertility. Stay tuned in. Let's Talk America Radio has more information and more exclusive interviews coming your way. Follow us on Facebook, TikTok, Instagram, YouTube, you name it, we're out there at LTA Radio. That's LTA Radio, or simply use the hashtag LTA Radio and you will certainly find us, okay? We aim to empower you with good information from exclusive advocates that are certified and trained, and they're legitimate in what they do, okay? Busting all of the myths out there with real education. Thank you, Dr. Lori Johnson, for joining us tonight.
You're so welcome.
Thank you. Amazing. Thank you, viewers, and of course, listeners, for watching us and tuning in tonight. And remember again to share this episode, and we'll see you soon. Stay tuned in and have a phenomenal spring and summer. Take care, everyone.